Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we're going to talk about developmental anomalies that can present as renal or nephrology pathologies. So there's a lot of really important ones like to test this on here, including Potter sequence, horseshoe kidney, solitary functioning kidney, duplex collecting system, posterior urethral valve, and vesicoureteral reflex. And I think the really key point here is to be able to compare and contrast, have one or two things that compares vesicoureteral reflex versus solitary functioning kidney. And that's the way you're going to be able to answer questions and get questions correct on test day. So the first one we're going to talk about here is Potter sequence. Potter sequence is a pathology that has to do with oligohydramnios. So let's unpack that word really quick. The root word oligo means low, and dramnios refers to amniotic fluid. So altogether we have low amniotic fluid in the placenta. And why is this a problem? Well, it's a problem for a variety of different reasons. If we have low amniotic fluid, we have low amniotic fluid ingestion. And this is really important to understand this pathophysiology. So essentially in utero, right, the kidneys will lead to urine production, urine will be excreted from the body, and then the fetus will actually ingest that urine, which helps it with lung development and some other physiologic processes. So the fluid that is actually circulating around, that is floating in, is essentially its own urine. And it's also important for another reason, in that it can lead to intrauterine compression. So imagine you're swimming in a pool and there's lots of fluid, you're swimming around, you can be buoyant, you can be even treading water in the deep end, but now you take away 90% of that fluid. Well, there's not a lot of ability to swim around anymore. You're not going to really be treading water in the deep end because there is no deep end. You're kind of compressed towards the bottom of the pool. And this is the same thing here for a fetus. It's compressed towards the placenta. They don't have that fluid to float around in, and this can lead to a lot of abnormalities from the intrauterine compression. And so if you draw your attention over here, there's kind of a classic memory that we like to use to discuss all of these findings that we see in Potter sequence, and that is to remember the word Potter. So we have pulmonary hypoplasia. Again, because we have oligohydramnios and decreased ingestion of amniotic fluid, the lungs are not developing as well. This ingestion of fluid is actually really important for lung development, and thus not having the ingestion is going to decrease lung development. So you get pulmonary hypoplasia or poor development or underdeveloped lungs. You also need to associate the O with oligohydramnios. Again, this is one of the key important things. The oligohydramnios is what leads to the pulmonary hypoplasia and leads to the intrauterine compression. This is where you can get the twisted face and the twisted skin. This is due to the uterine compression. So imagine the fetus's face is actually smashed against the placenta because it doesn't have the fluid around which allows it to float. You're also going to have extremity involvement, again relating to the compression, and the R is for renal involvement. So altogether, we have the word Potter to remember the key points of Potter sequence: pulmonary hypoplasia, oligohydramnios, twisted facies, and extremity involvement, as well as the renal involvement. And really knowing this is most of what you need to know to get questions right on test day. Now, it's also important to know that some of the internal deformities are referring to pulmonary hypoplasia, and the external deformities are referring to the facial and limb abnormalities. So it's both an internal and external way. When a patient is born and they've had Potter sequence, we can see this on physical exam, but there's also some internal things that we need to be mindful of, such as the pulmonary hypoplasia. Now, key associations they like you to know include renal agenesis or lack of formation of the kidney, PUV or posterior urethral valves, we'll talk more about that shortly, placental insufficiency, and ARPKD, which is autosomal recessive polycystic kidney disease. So anything that causes an obstruction, such as in PUV, or the inability to actually create the urine that is actually used to create the placental fluid, such as kidney disease or renal agenesis, lack of kidney formation, can lead to this condition. And so put in other words, if we don't have a kidney or we don't have a functioning kidney, we're not creating the urine, we're not having this urinary process, it's not being excreted from the body, fluid levels are going to drop in the placenta itself, which is going to lead to problems with lung formation. Now, moving on to the next important pathology I'd like you to know, it is horseshoe kidney. And horseshoe kidney is due to fusion of the inferior poles, which inhibits renal ascension by the inferior mesenteric artery, and the kidney remains inferiorly displaced. So here's a really nice image over here. You can see the inferior poles have actually fused. Normally these would come apart, and so that you'd have two kidneys that are ascending on each side. But if they're hooked at the bottom, right, if the poles are fused, well, now you have the kidneys and they get stuck. They're unable to ascend past the mesenteric artery. Now you might be asking yourself, does this have any problems for the patients? And the answer is typically no. You typically have a normal functioning kidney, right? There's no problem with the development. There's no problem with the function. It's purely the fact that they are located below where we would expect them to be. And if you look over here to the CT scan, there's a really nice image right here, that high yield image that they want you to know that this shows, right? There's no separation here. This is conjoined. The inferior poles are conjoined together. And this is a classic CT of a horseshoe kidney. Now, what are some associations? We said those are important. They like us to know those. These include things like increased risk with trisomies, such as 13, 18, 21, as well as Turner syndrome. And there's also increased risk of hydronephrosis, infection, nephrolithiasis or kidney stones, and renal cancer. These are just important associations that they like you to know. And really, I just think about these associations as if somebody has a horseshoe kidney, they're at a higher risk of having other renal complications, of which these are some of the common ones that you can experience. Now, moving on to the next one, we have solitary functioning kidney, which put another way is saying that we have one kidney functioning out of our typical two, and this can be either a functional deficit or an actual anatomic deficit. So first, let's talk about the functional version, and this is going to be most commonly asked about in multicystic dysplastic kidney. This is due to failure of the ureteric bud differentiation, which leads to a non-functioning cystic kidney. Typically, it's unilateral and is asymptomatic. Now, if a patient has this bilaterally, we're going to get a Potter sequence type presentation. And the reason is because if we have both kidneys not working, well, what's that going to do? It's going to lead to oligohydramnios. And we talked about this cascade earlier, decreased amniotic fluid, and the Potter presentation of pulmonary hypoplasia, abnormal extremities, which are a result of oligohydramnios, not producing enough urine and thus not having enough amniotic fluid as well. Now, the reason I highlighted the word differentiation here is because it's slightly different than our anatomical variant, which is renal agenesis, where you have a failure of the ureteric bud development. So it's not that the differentiation is a problem, it's that it doesn't actually develop at all. You have absence of the ureteric bud, and thus you have an absent kidney and ureter. Again, if this is unilateral, it's going to be asymptomatic. However, if it's bilateral, it's going to present with a Potter sequence presentation for the exact same reasons we just talked about. So again, solitary functioning kidney is essentially just saying that one of the kidneys is functioning compared to the typical two. Two primary ways this can occur. It can present as multicystic dysplastic, which is a functional deficit, right? The kidney is there, but it's functionally not working, so it might as well not be there. Or it can present as an anatomical deficit where it's literally not there, and thus, of course, it can't do its function as well. Moving on to the next pathology, we have the duplex collecting system. This is due to a duplication of the collecting duct system. This can be complete versus incomplete. And what do I mean by that? Well, in a complete duplex collecting system, an additional ureteric bud actually forms. And so we have two of them that are interacting with the metanephric blastema, a structure that it typically interacts with, where the kidney and the ureter actually form together. And this leads to two ureters being formed with the one kidney. Now, in an incomplete version of the duplex collecting system, we have the same ureteric bud, but instead of simply duplicating and making a second one, which we talked about incomplete, we now have the one ureteric bud that actually splits. And so now we have one ureteric bud that's actually split into essentially two smaller versions of itself rather than full-on or complete duplication. What happens here is that we get a bifid ureter, or a ureter that actually merges at the UPJ. And so if we were to draw a picture for this, we would see a complete. We have two different ureters going in the bladder itself, so 1 and 2, this being the kidney, this being the bladder. But in incomplete, we only have one entry point into the bladder itself, but it's split higher up in the kidney. So we have this bifid ureter process. And so this should make sense to you. Again, we have two complete different ureters versus here it's incomplete. We partially have incomplete ureters, but it actually comes to a complete area as it enters the bladder and the UPJ as well. And finally, some key associations that they want you to be mindful of include the association with VUR, or vesicoureteral reflux, ureteral obstruction, and the increased risk of UTIs. Now, moving on to posterior urethral valves, a super important one that I'd like to ask you about. We talked about some associations elsewhere, such as with Potter sequence, where PUV or posterior urethral valve can actually be associated with Potter sequence. It can actually lead to Potter sequence in a way, and we'll talk about why. So in posterior urethral valves, you have the posterior urethra membrane remnant in males that can lead to bladder outlet obstruction. And this is important because it's the most common cause of urinary tract obstruction in newborn males, and that's why they like to ask about it. And so if you draw your attention to this image right here, this will make sense to us why this can lead to oligohydramnios. So we see that we have the ureters going into the bladders bilaterally, right? In patients who have PUV or posterior urethral valves, they have a membranous fold near the posterior urethra. So the posterior urethra is essentially this portion right here. Further down, not drawn, is shown the anterior urethra. So we have the bladder going to the posterior urethra, which would follow the anterior urethra later on. But really focusing on the posterior urethra right here, these membranous folds can actually cause an obstruction because urine's making its way down from the kidneys, right? It goes into the bladder, it fills up the bladder, and then it wants to leave through the urethra. But if you can appreciate this obstruction is in the way, this can make it harder for the urine to actually keep moving forward. It's an obstruction to the system. Well, what's going to happen? Well, we can get a backup of urine in the bladder. This is going to back up into the ureters, and ultimately it's going to back up into the kidneys itself. So the normal sized kidneys are now going to become super enlarged and even full of fluid in a term that we call hydronephrosis. So again, this obstruction, the posterior urethral valve, this kind of remnant membranous fold that does not go away as it typically should, is a common pathology they like to ask you about on test day. Again, the obstruction is going to lead to decreased urine production, oligohydramnios, which we can appreciate why this would now make Potter sequence a possibility for a lot of these patients. And so some of the associations should really make sense to us, such as the bilateral hydronephrosis, thickened bladder walls, oligohydramnios, and severe obstruction, which can be associated with Potter sequence as well. And the final pathology we're going to talk about for this video is vesicoureteral reflux. So the term vesico refers to the bladder, and ureteral, of course, refers to the ureters. Reflux means that flow is going backwards. So normally we have flow go from the kidneys to the ureters to the bladder and leave the body. But in reflux, right, that indicates that it's going backwards, or we're getting retrograde flow. It's going the opposite direction, which we would expect. There's two primary ways this can occur. In primary VUR, we have abnormal UVJ insertion. UVJ stands for ureterovesical junction. Now, this is going to lead to retrograde flow, and why is that? Well, typically the ureter passes into the bladder, and the valve will actually close as the bladder fills up. But in patients who have an abnormal insertion, this area does not actually close up as the bladder fills with urine, and this leads to the retrograde flow because there's no closing off at the junction that we would typically have. If it remains continuously open, we can get that retrograde flow in the kidney. Now, in secondary VUR, there's increased bladder pressure somewhere in the urinary tract, which also leads to retrograde urine flow. This can often be due to a urinary tract infection, which causes inflammation in the ureter itself, causing them to have a smaller lumen. This can lead to increased pressure and the retrograde flow as well. It's also associated with renal complications such as CKD. Scarring in the kidney, right, is going to lead to obstruction as well. Ureters are not as patent, they're not as open. Urine has a harder time moving forward, and thus it gets sent backwards as the pressure builds up. And it's also associated with children typically under 2 years old. So a classic patient presentation they could have for these pathologies includes something along the lines of a newborn patient is born at 39 weeks. Upon delivery, the patient is gasping for air and appears slightly cyanotic. The question then goes on to ask, which of the following congenital anomalies is most likely in this patient given his presentation? And the correct answer here, although you might be considering all of these options such as Potter sequence, horseshoe kidney, solitary functioning kidney, duplex collecting, posterior urethral valves, and vesicoureteral reflex, would be the posterior urethral valves. This is the most likely thing that is leading to what's potentially a Potter sequence in this patient. They're gasping for air, maybe their lungs are underdeveloped. Question might also talk more about the changes in their extremities, how they look a little bit unusual or twisted as we talked about. But the reason, the question is asking, what's the reason this occurred? It's because the posterior urethral valves. And the reason this is the best answer is because this is the most common form of obstruction in newborn male infants. Now, just a quick summary for this video. Lots of pathologies here. Again, I stand by what I said at the beginning. I think the best way to do this is to look at all these pathologies and say, what are one or two things that I can use to differentiate from other types of pathologies? That's how they're going to get you on test day. They want you to say, can I look at all of these pathologies? Do I know the difference between horseshoe kidney and solitary functioning kidney? So for Potter sequence, I think this memory aid is like super high yield and really easy to remember and important. And the main thing is it has to do with oligohydramnios leading to a bunch of downstream effects. With horseshoe kidney, I think it's important to notice what's actually happening here and that it's getting caught in the inferior mesenteric artery and that it's associated with a lot of these other conditions as well. I think they like to ask those conditions saying something along the lines of a patient with Turner syndrome presents what other pathology is associated, of which horseshoe kidney would be a reasonable option to pick for this one. For solitary functioning kidney, less commonly asked about, but a real differentiating feature they want you to know is the difference between functional and anatomic deficits. This has to do with failure of differentiation versus failure of development. For duplex collecting system, we talked about complete versus incomplete. The idea here being that we either have two separate ureters or we have one ureter that actually splits into two in the proximal portions. When we talk about posterior urethral valves, main things here is it's very common in male infants, so they want you to know that. Also want you to know kind of an idea of how it actually works, right? It's the membranous folds that don't go away, leading to the backflow or the obstruction in the urinary system. And finally, we wrapped up with VUR or vesicoureteral reflex, primary due to an abnormal insertion point, secondary due to a variety of different causes that lead to narrowing or inflammation in the bladder itself. And again, it's called vesicoureteral reflex because we have an obstruction and then we get reflex. Instead of urine continuously going forward, it actually refluxes and goes backwards into the kidneys itself.